Welcome to the Pharmacy Quality Solutions Quality Corner Show, where we talk quality of healthcare and explore what that actually means. Let's dig into performance measurements, the equipped platform, pharmacy goals, and personal goals. We will also occasionally cover topical healthcare news and maybe throw into the conversation a few of our own nerdy passions and hobbies. So turn us up. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. This is your host, Nick Dorich, and we welcome you to episode number 30 of the Quality Corner Show. In a continuation of some of the highlights from PQA's virtual meeting in May, we have the pleasure of speaking with one of the presenters of the session on exploring drivers of community pharmacy level performance on adherence measures. That's Ben Urick, PharmD, PhD from the UNC Eshelman School of Pharmacy. Ben also helped with last year's trend report in pharmacy quality and is a friend of PQS. Hello, Ben. Welcome to the show. We are excited to talk about these drivers of community pharmacy and level performance on adherence measures. But first, we'd love to get a bit of background from you.
Excellent. Yeah, thanks, Nick. I'm glad to be on and am happy to have the chance to nerd out with you about quality measures and adherence.
All right. So, Ben, before we get into the topic, do you mind explaining some of your background, whether it be from a research perspective, community pharmacy perspective, what has gotten you to become interested in this topic?
Yeah, absolutely. So as you mentioned, I'm a PharmD PhD. So I got my PharmD from Drake University back in 2011, go Bulldogs, and then started immediately into the PhD program at the University of Iowa after that. So, you know, Drake is a 2+4 type program. Primarily when I was there, it was a 2+4 type program. So I went into pharmacy thinking that I was going to do community pharmacy practice because that's what I knew. I really liked chemistry in high school. I went on a job shadow at a Walgreens and asked the person if they ever use chemistry or organic chemistry, and they sort of scratched their head a little bit and bless their heart, they went over and grabbed a bottle of generic Bactrim and pulled the package insert off, opened it up, and said, "This is a sulfa group," pointing to the sulfa group on the sulfamethoxazole moiety. And so I said, "By God, you use chemistry all the time in pharmacy. Pharmacy is for me." And so bless their heart from trying so hard to force chemistry into every day within community pharmacy. But so I went into pharmacy school thinking I was going to be a community pharmacist. Sort of, went on a little bit of a journey through pharmacy school as I want to do, sort of thinking, who am I and what do I want to do, and thought about residency a little bit, but realized that, clinical pharmacy wasn't going to be the thing that would, get me out of bed every day. I'd seen that passion in my wife who I was dating at the time, but I recognized that was not within me. At the same time, I found out that I really, really enjoyed research. I enjoyed sort of that process of discovery, that idea that you can discover new knowledge, and then once you discover it, it's up to you to try to spread it with as many people as you possibly can. And I got that research bug when I was in pharmacy school, and really it's because of that and the idea that I could teach and work with pharmacy students to get my sort of interpersonal kicks out, because it turns out that students are people too, and working with them gave me the same sort of excitement that I did when I worked with my patients. Ended up doing a PhD at the University of Iowa immediately after my PharmD. And so, in terms of my community pharmacy experience, I certainly worked as a technician all the way through pharmacy school, and I actually worked for a couple of years at a large national chain, and then also worked for a couple of years at a small regional chain while I was in the PhD program. So that gave me enough of a grounding to understand, to have, I would hope, a decent sense of what's happening in practice, at least, from that time. And I enjoyed combining that with my PhD, experience. And as I entered into my dissertation phase, I was starting to think about sort of what could I do for my dissertation that was kind of most closely related to pharmacy practice, and also as a good intersection of my interest in quality measurement and data that was growing. And this is 2015, and probably a lot of people listening, and certainly PQS knows that 2015, kind of leading into 2015, was a year of a lot of excitement for performance-based pharmacy payment models. There were a couple of early models that were being launched about that time, and I realized that for me as a researcher, I could do research that was relevant to the idea of performance-based pharmacy payment models. and try to come up with something that, might have a bit of a stronger theoretical design than what I had seen actually implemented. So that's what I did for my dissertation. I ended up doing a dissertation on performance-based pharmacy payment models and sort of a value framework for pharmacies, and that got published in Research in Social Administrative Pharmacy last year. And then in 2016, I started at UNC at their Center for Medication Optimization. And as a part of that, I worked on the Community Pharmacy Enhanced Services Network project in North Carolina, which was operated by Community Care North Carolina and funded by the Center for Medicare and Medicaid Innovation. So that was a big project, and my role in that was to evaluate if that alternative payment model was effective at improving outcomes and lowering costs. So did that for a couple of years, and then have transitioned over for about the last year and a half into my own research, which a lot of it focuses in two areas. One is the impact of pharmacy services on healthcare value, and the second is reliability and validity of provider-level performance measures. And I think I've got some research from both those areas that we can talk about today, and that was also highlighted a bit in my presentation at the PQA annual meeting.
Yeah, thanks, Ben, for the background. And it's certainly good for us to have pharmacists that are involved in our understanding data, understanding measurements. If we as pharmacists are not talking about it, other people will be talking about it for us. So it's good to have folks like yourself that are involved. And I am told that with this podcast, and you're at UNC. I've been told that I need to make sure to note that we've got a number of UNC fans at our PQS office. I think that's more basketball related, but maybe not for the 2019-2020 season, since that wasn't going too well for UNC. But let's go ahead and jump into our questions for today. And with quality improvement, there's always this inherent element that evaluation or measurement improves or becomes updated based on new guidelines, new data sets, new findings, and based on prior performance measurements. So Ben, let's learn more about your project. And that project was referenced Exploring Drivers of Community Pharmacy Level Performance on Adherence Measures. So can you help us explain how your research on this topic points to opportunities for quality measures to consider elements of pharmacy practice?
Yeah, sure. So, this project was an opportunity for my co-presenters and I to highlight our work and others' work which we admire in the context of the National Quality Forum's validity framework. So the NQF defines validity in two ways. The first is the validity of data elements themselves, and the second is the validity of measure scores. So within that sort of two-factor construct, the first really talks about is what you're measuring accurate in the sense that, for adherence, we know, for example, that adherence is somewhat of an indirect method when you use the proportion of days covered method. If you really, truly want to measure adherence, you have to actually directly observe patients taking that medication. Now, this is done on occasion. For example, patients with TB, there is sort of direct observation by nurses. That is still a standard of practice. But as we all know, it's totally unfeasible to do anything like that for, entire population of patients with diabetes, high cholesterol, et cetera. So, because of that, we're sort of left with this indirect method, which is proportion of days covered. And it's convenient in a lot of ways. You can build PDC with a variety of different types of observational data sets. And, PDC is well correlated with outcomes. There's, great work by people, for example, like Tish Chowdhury, who have done a lot of work on, adherence and looking at the relationship between adherence and measuring it observationally and outcomes. And you do find that even though it's not perfect, adherence measured observationally through things like PDC does correlate well with things like outcomes, like, for example, heart attack rates in patients with statins, where you would expect there to be some kind of correlation there. So that speaks to validity of this data element. Now, I would say that a lot of the research that has been done around linking adherence to outcomes is a little old, in the order of kind of several years old at this point in time, which isn't old, but it's got enough age on it that, by the time something gets published, we're probably talking about maybe 5 years ago worth of data. But what we've seen recently is that there's been a lot of upward trend in proportion of days covered, especially in Medicare. For example, if you look at the Medicare STARS rating program, you've seen STARS rating, thresholds increasing by, let's say, 8 percentage points, 10 percentage points over the last 7 years, which is a huge increase and clinically significant if it's actually true. But I think that you have to look at that and you have to ask yourself, is it really true that we're seeing 8 to 10% more patients actually taking the medication as the doctor intended? Or might there be some biasing in these measures that is causing some of this upward trend and inflation? If we think about the potential for really threats to validity of this data element, these things that might bias this measurement, I think two pretty common examples would be things like auto refill programs and 90-day fill rates. So, if you look at auto refill programs, or even I would probably broaden that out to any kind of scheduled refill program where you're really kind of trying to pull refills from patients. Research has shown that those programs do increase adherence as observed by PDC. I'll point you to a 2016 study done by colleagues from University of Wisconsin. Michelle Chewy, Dave Ma, Corey Lester up there. So, what they found is that an auto refill program increased odds of adherence by about 1.2, 1.5, which is quite a lot. But when they looked at it a little bit closer, what they found is that the reason why patients had increased PDC with the auto refill program wasn't necessarily because they were actually exposed to the medication more. It was because the medication sat on the shelf longer. And that time the medication spent on the shelf, that still counts in the PDC calculation, because when you calculate PDCs, all you have to go on in most administrative databases is just the date on which the prescription was adjudicated. And so you sort of had to assume that that's close enough to the actual pickup date. But again, they found that this particular auto refill program ended up causing the bag to sit on the shelf for longer. And when they corrected for that, looking at pickup date, they actually didn't find a positive effect. So, I would say that that's one. Another one that's really common is 90-day fills. There is sound logic to 90-day fills, right? Because, the fewer times a patient has to go to a pharmacy, the more likely they are to perhaps take it because they're not as prone to forgetting. And, from my time in the community pharmacy, I know that there are patients who be like, I meant to pick that up, but I just forgot. It's still going to be on the shelf on Monday. And so reduces those sorts of just kind of pure forgetfulness errors. But from a PDC calculation method, it also reduces then the opportunity to observe gaps in coverage. And so by simply observing fewer gaps in coverage, you are just by the nature of a 90-day fill and its relationship to the PDC calculation going to observe higher adherence, because you have so many more opportunities for observations of gaps in coverage when you have a 30-day fill. With 30-day fills, you have potentially 11 times a year where a patient can be unexposed to medication, versus with 90, it's only 3. So, do 90-day fills actually increase the rate in which patients take the medication as intended? Perhaps. But, I think there's also reason to suspect that a lot of what it's doing is simply inflating PDC, and then again, perhaps weakening this relationship between PDC, the measurement of PDC, and that true, actual, factual adherence, which is patients putting pills in their mouths as intended. So, I would say taking all of that into summary, is PDC a valid method from the data element level? I would still say that it is. There's sound logic. There's the C. Everett Koop quote, and I hope I'm not misquoting this. It says essentially, drugs don't work in patients who don't take them, which is obvious, right? So I think PDC still makes sense. Certainly it's a pragmatic approach. I think where we can get to is thinking through alternative measures that maybe rely on or expand the PDC method, and then also looking at measuring PDC in different classes, getting outside the statin, diabetes, and renin-angiotensin system antagonists that I'm sure most people that are listening to this are familiar with, and thinking about getting into additional classes of medications and then summarizing across as a way to create adherence measures which are perhaps a little bit less subject to bias.
Yeah, so Ben, I'm going to give it a little bit of a summary here, some of the points, and I may put a pin in one of the items here for a follow-up just in terms of time for our conversation. But when we're looking at the data, when we're looking at the sets, these measures still valid, but these are measures that were developed and endorsed a number of years ago. And as other data sets become available, it's perhaps worthwhile for further evaluation. I look at this, and Ben, you and I both graduated pharmacy school in 2011. It's the kind of thing where if we were practicing clinical guidelines that were based in 2011, that's good for 2011, but there may be updates that need to be reflected as we hit 2020 as an example. And this may be an opportunity for further exploration when it does come to quality measures and evaluation. So Ben, I want to get into some additional items on your presentation and some of the key takeaways that you had. This is the part that was really interesting to me. And you referenced some of these items in your introductory remarks here, or remarks to the first question rather. Can you explain the relationship between quality measures and, one, the environmental factors, and then two, characteristics or services provided by the pharmacy? I think you referenced this again a little bit in the prior discussion, and it's not to say that those are completely the reason why a pharmacy is successful or fails with a quality measure performance, but it certainly does sound like there is a strong impact that's there, and that as we go forward with quality measure evaluation, that items should be taken into consideration. So do you mind explaining those concepts for our audience?
Yeah, sure. So, this relates to the other piece of the NQF's definition of validity is so you have to have valid data elements, but then there's a question of even if you have valid data elements, is that still meaningful when you end up looking at the validity of the measure score? So essentially, you can have a valid data element, but that doesn't necessarily mean that your observations of performance at the pharmacy level are going to be valid. And reasons why I would say oftentimes revolve around the idea of these environmental factors, as you mentioned, as well as just sort of kind of random noise that perhaps distracts from these care quality signals that we hope are there. So environmental factors make up this noise that kind of distracts from this signal, which is these actual services that these pharmacies are providing, which should improve adherence. And so we can try to get a sense of these signals and get a sense of this noise through some of the literature that has been published by others, as well as some of the work that I have done. So first, if you think about environmental factors, there's a lot of research that has gone into why patients aren't adherent, and there's a pretty well-established literature base around things like patients' health status, patients' age, oftentimes patients who are non-white or of lower socioeconomic status have lower adherence rates than patients who are sort of healthier, wealthier, and frankly whiter than others. And so, pharmacies, community pharmacies serve their surrounding communities fundamentally. And so if a pharmacy is in a community that itself is less likely to be adherent to medications, that pharmacy is going to have worse quality scores, regardless of what that pharmacy can do in terms of performance. So, a couple of things that I want to highlight. There's some work done by colleagues down at the University of Mississippi looking at just even adjusting at the state level. And they found that, the Southeast, if you were to actually risk adjust on some of these items that I mentioned before, you actually see the Southeast end up performing a little bit better on adherence scores. And states that are in the North and the Northwest end up scoring a little bit worse on adherence scores, which is to say the South is scoring worse because of the demographics of the South, and the North is scoring better because of the demographics of the North. And there's also some work done actually by PQS that looked at predictors of low performance and found, for example, pharmacies in communities with a higher proportion of older African-American patients were much more likely to be low performing. So, risk adjustment is the standard way of adjusting for these things, and I would emphasize that risk adjustment needs to be considered if we're going to say that inference made in adherence at the pharmacy level is valid.
Ben, thanks for that explanation with the environmental factors. Can you dig into characteristics and services provided by the pharmacy?
Yeah, absolutely. So when you think about characteristics or services provided by the pharmacy, really what we're looking at here is trying to identify these signals of care quality that should correlate with adherence scores if the adherence score is really a valid measure of pharmacy performance. And in work that I've done with the North Carolina Community Pharmacy Enhanced Services Network, as I mentioned earlier, being a part of that project, finds that there are some services which do appear to drive better adherence. So for example, offering home medication delivery I've got 2 studies on that ended up finding that is well correlated. And then additionally, we also found that multi-dose compliance packaging, which again, this makes sense, but offering multi-dose compliance packaging is another characteristic from the network that we found was positively correlated with adherence scores. And that finding on offering multi-dose compliance package is actually coming out next month in JMCP. So I would refer you to that manuscript once it is published for a little bit more detail on what we found in terms of the correlation between characteristics and those quality scores. So, what that tells me is that even though, like I said, there are these environmental factors which create this noise, there are some questions around the actual validity of the PDC method at the data element level. But even considering all those caveats, because we still do see that there are these services which drive performance, that suggests to me that there is validity to the idea of measuring adherence at the pharmacy level using even current methods.
Yeah, so Ben, this has me thinking about how we best use this information. And the part that I want to make clear is it's that certain services or characteristics of certain populations that may help drive adherence one way or may make performance lower in some areas that's there, but that's not the be all end all. And there's always, that's kind of the external part, right? That's what the pharmacy maybe can't control, but there's also a part of it that's internal. And what we want to be able to better understand and get more data points that's there so we can understand what are those community factors, but also there's going to be an element as it relates to services, how successful a pharmacy is with those services, how they're presented to a community that they have. So it's an area where more data is going to be a good thing. More data is going to be our friend to help provide a better system and a better understanding of healthcare and the work ultimately that is provided by pharmacists and by pharmacies to improve these health outcomes. So we'll move here to our third question, and we referenced earlier in the recording that quality measures are based on data, clinical guidelines, and better availability of data. Your presentation of this material at PQA is helpful for consideration with a measure developer as they continuously review measures that have been endorsed. My question here, Ben, is what can or should a pharmacy do to help continue that data conversation? It sounds to me like pharmacies and those in public health need to have a better understanding and utilization of the measures so that they can help provide increasingly more data and more informed feedback so that we can have good, effective measures. Would that be a correct summary of the next steps or a call to action? What do you hope that listeners, or what do you hope those that have reviewed your presentation, what do you hope that they get out of this?
Yeah, I would say that pharmacy engagement is key. You can look to literature from things like paper performance models for physicians, and they found that the more informed and engaged a physician is, the greater likelihood that they will succeed in those models, and the greater likelihood that those models in general will succeed. Other work that I've done surveying community pharmacy owners and their perceptions of paper performance models finds that there is a lot of confusion and frustration out there. I'll point any listeners to the PQS website. PQS website has now quite a large library of videos, and the videos are excellent in terms of teaching tools for informing on how measures are developed and how they're actually used as a part of the QUIP. I actually use them some in the classroom to help students understand these concepts. And so, I think also there can be assistance by the payer. In this survey that I've done, pharmacies are confused as to how cut points are scored. A lot of those decisions really are payer decisions, and payers can do a better job communicating those to pharmacies. And I would also encourage payers to directly engage pharmacies in number one, the upfront design for any new model, and number two, as these models are maintained and change over time, having engaged pharmacists in that conversation can make a huge difference. Again, there's good literature out there from physician group practices and pay for performance models. And I think that we can learn from that literature on best ways to engage with providers as part of these models and bring some of that into pharmacy practice to help improve ultimately the patient care that results from these kind of incentives that are created.
Yeah, my takeaway, Ben, quality improvement, it's a game that we are all engaged with, right? So that's the practitioners, that is the payers, that's the measure developers, that's CMS. Everybody's got a role to play in this. And it's important for everybody to be improving their education, taking action steps, and it's important to understand how you improve documentation and data there that goes into it. We want to get better, but it's going to be taking everybody moving in that direction to get there. So Ben, this has been a very fascinating and really great exploration of data and quality measures, and I appreciate that you've taken some time to share with our audience. We have now hit the point of our podcast that we get to have a little bit more fun with our guest. So Ben, I know that you are a man of many talents, and that includes that you do play the trombone. So I can personally say I've been to some of your performance and that I can personally attest to your level of talent. We'll blend this question in with pharmacy for you. So when you are playing with a band, it's many team members working in unison to create this wonderful audience experience. As we expand the role and capabilities of the pharmacist, what are the major opportunities that pharmacy must seize so that we can be operating as a member of the quote unquote healthcare band?
So I love this question. This is great. So as you mentioned, music is a passion of mine. Play the trombone, also a little bit of baritone, trumpet, and the alp horn, which is the 12-foot-long Ricola horn, and a whole variety of ensembles. So, I think if we're to bring this over into the pharmacy context, I would say no matter what band you're playing in, one thing that's absolutely critical is listening to other members of the band while you're playing your own part. And really they need to listen to you as well. And if you're in an ensemble that isn't listening to each other, you can't make good music. I can tell you from doing some COVID-related recordings and trying to send those in to produce sort of a video band, it's just not nearly as fulfilling, and it's not nearly as good a result if you're not there actually listening to everyone else as you're playing your own part. So I think bringing this into the healthcare context, it's really around interoperability and creating these effective data exchanges between pharmacies and other members of the healthcare team, or thinking about platforms, also creating data bridges, right? So if pharmacy can't tap directly into an EMR, can there be a bridge created so that relevant EMR data can be brought from the EMR, aggregated, and then pharmacy is able to access that data through some platform, be that Equip or something else? I think that interoperability allows pharmacists to do what pharmacists do best and how efficient is it, physicians to do what physicians do best, so that the pharmacist isn't trying to sort of create redundant tests that the physician's already done, thinking about potential future measures like A1C or blood pressure, and that the physician can be aware of what the pharmacist is doing to help co-manage their patients. And by having greater interoperability and better communication across, it allows this healthcare band to play better. It allows the trombonist to be the trombonist, the flautist to be the flautist, the percussionist to be the percussionist. And then when you're playing everyone together and everyone's doing their instrument to the best job that they can, that's when you get the best result from this healthcare symphony.
I referenced in a few episodes ago that pharmacists are often referenced as the most convenient healthcare provider and that they're one of the most trusted. Those two features of pharmacist or pharmacy only really mean something if we take advantage and if we utilize the pharmacist with those capabilities. So absolutely, we need to further explore. We need to really put pharmacists front and center as that face of healthcare and as that community resource. I've seen throughout this experience with COVID that's never been more important. And certainly while we are dealing with the COVID situation as it is, and pharmacists continue to be a resource, there's going to be other opportunities where pharmacists can play a larger role in chronic care management and helping patients understand acute medical conditions. And pharmacists, I would say to that, get ready, because we're really just starting that roller coaster, but it is going to be a great experience. Ben, it's been wonderful having you on today's podcast, and I appreciate you sharing these findings with us today. I'd love to have you on for another recording in the future, and I don't think it'll be that difficult to twist your arm and get you back on here to talk. Do you mind? I know folks can check out some of your information from the PQA meeting if they're a member and see some of those resources. Is there anything else that you would recommend for our audience to check out? Maybe your upcoming article in JMCP, but anything else you'd like to have them go so they can learn more information from you?
Yeah, sure. So like I said, this is a bit of self promotion, but let it be that. The upcoming article in James CP, I think, is, I want to see more research like that, and so I encourage people to read that article and to consider what those characteristics are. Certainly if you're just looking for connection, my faculty page at UNC is great. Or, I always love connecting with people who are, on the ground experiencing this. And so feel free to reach out by email. I'd love to chat. You can find my email on the UNC faculty page. Just Google my name, UNC, and shoot me an email. Love to connect with anyone who wants to talk about pharmacy quality.
And thanks for your openness with that. We appreciate you joining on for the show once again. And we also appreciate our listeners tuning into another episode of the Quality Corner Show. Hopefully you have found this episode enlightening and informative. With that, and looking at the time, I see that it's about time that we close out this show. Our team here at PQS has a couple of favors to ask of you, our podcast listener. First, we encourage you to share this podcast with 2 friends, because if you share this with 2 friends, each of them shares it with 2 friends, it really helps us hit a larger listening audience. Second, we also want to take a moment to remind you to subscribe to the podcast wherever you may find it. And then, if you have any questions or topics you would like us to address, please contact us. The best way to do so is to email info@pharmacyquality.com. Let us know what is on your mind and what we can address so that you are fully informed. Our goal is to continuously improve our podcast content and to provide meaningful information to our listeners based on the current topics in healthcare, technology, and quality measurement. We want to help you become as effective as possible in how you care for patients and improve public health outcomes. So until next time, we wish you well.